Nice. Welcome, everybody. My name is Marty Mascari. I'm with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center. We welcome you all today, once again, for our partnership with Dr. Ron Mottern to talk about appropriate approaches to responding to people with psychosis. I apologize. Something popped up and I got on my way here for a minute. I'm sorry. So that being said, we're going to go ahead and move to the next slide if we could and talk a little bit about CEUs before we get started. For those of you that are interested in CEUs or certificates of attendance. So the rules, I guess, or the guidelines are going to be the same for both certificates, whether you're looking for a certificate for your licensure or you're looking for just a certificate of attendance today for your work or whatever other reason you might need it. But today we're offering the CEUs for licensed social workers and licensed professional counselors. Certificates of attendance are available to anyone who would like them. Now, we are licensed in the state of Texas, or set up in the state of Texas, to provide CEUs for the licensed social workers, licensed professional counselors. I have had people join us for webinars that have gotten the CEU certificates and use them for other licenses, either within Texas or outside of Texas. But please understand that we are not set up with them. There's no guarantee that anybody will accept them, but you're more than welcome to grab the CEU certificate if you think that's going to better serve your purpose. Either one, it doesn't make any difference to us. Joining us for today's webinar is good for 1.5 hours classroom hours of CEUs. You must complete the entire live webinar. That means you can't miss more than 5 or 10 minutes of the webinar to be eligible for these. We really get audited. I get a report from Zoom that tells us how many minutes you participated, and that's what I have to use as the backup for my documentation if I'm ever audited, and I have been audited before. You also need to complete the Google survey evaluation form. We're asking everyone to complete it because this is not only for the CEUs we use this for, but we also use this to document our outcomes for our funders for the objectives that we put forth when we applied for funding to be able to host these webinars. So please, everyone, if you'll complete the Google survey, it should pop up as you close out of the webinar today. But you will also receive it. Anybody that's joining us will be receiving a follow-up email from me within the next 24 hours that will include the link to that survey, as well as the link to the slides for today's presentation. You should have also received the slides in your reminder email today, the link to them. I'll post that link in the chat here in just a minute, but those are a link to Dr. Mottern's slides if you want to take notes or just save those for review. The Google survey will stay open until 5 p.m. from a week from today till June 1st, and the certificates should go out within the next week. I am behind on certificates and recordings. I was out of town and came back and had several technical issues that I had to deal with, and I'm still trying to catch up. I've resolved the technical issues, but still trying to catch up with both CEUs, but most importantly with the recordings, getting them processed. One of the things I want to add, I just want to say is, I want to be fair to everybody, but I know there's a lot of people that join us that stay on these and watch them. I'm concerned that there's people that log in and don't pay attention, because I get some emails from people asking for their CEU certificate, and when I ask them, did you complete the documentation, they come back and ask me what documentation. Well, we go over this twice during the webinar, so please make sure that you stay with us and watch and know what's going on, so you're not coming back with questions like that. I've gotten to the point where I kind of bounce back with questions, just because I don't think it's fair for those of you that have stayed on and actually watched the webinar and to get your CEU certificates, and other of them may not be paying attention and expect to get the CEU certificate as well. So Next, I want to introduce Dr. Mottern. If we'll go to our next slide, that would be great. Dr. Mottern, he's executive director of the Mottern Institute for Mind-Body Wellness. He has 22 years of experience with in-person and worldwide virtual treatment in cognitive restructuring, behavior modification, emotional regulation, physical improvement. And he's the publisher of a book called Living Well, A Guide to Cognitive Behavioral Skill Exercises. And I can tell you, I have the book, it's great. And I think that's available on Amazon or whatever, but the book's great, I can tell you. So I'm going to turn it over to Dr. Mottern and let him take it from here.
Okay, thank you, Marty. Glad to be back once again today talking about a fascinating topic, the topic of psychosis. It's sometimes confusing to people, but hopefully we'll go through this and come away with a little better understanding of what that is. I want to look at what is psychosis. First of all, the difference between psychosis and neuroses, although neurosis is not commonly used these days, except perhaps in the big five personality traits. But we want to look at that because that term will sometimes come up and distinguish between those. Then we want to look at psychosis versus psychopathy, which is also something that sometimes people confuse. So just make a distinction on those. And then I want to look at, when we talk about psychosis, we're really talking about schizophrenia primarily, but there are other psychotic disorders as well. And I'm not going to look at all of them. I'm going to look at the ones that I think the audience might run into, something that they might encounter in their daily lives. So brief psychotic disorder, that may be something that people run into. Schizophrenia, certainly. The substance medication-induced psychotic disorder may run into that, especially if you have, if you're caring for people on medication and things like that. Then psychotic disorder due to another medical condition. And then catatonia. Catatonia is just sort of thrown in there because it's very similar to psychosis, so we'll sort of look at that. And then also, how do you deal with that, right? We'll look at some psychotherapy, some ways to deal with that with psychotherapy, and then also medication. And we'll look at some of those medications that have been around for some time, and then some atypical medications that are newer, and how those can help. Okay, so what is psychosis? Well, I recall my very first psychology course, Psych 101, when I was an undergraduate in college, and the professor was a psychiatrist, and I will never forget him when he was describing the difference between psychoses and neuroses. Right? He said, neurotics build castles in the air, and psychotics live in them. Okay, so, and that's a pretty good definition of that. Okay, that's a pretty good definition of the difference between the two. When we talk about neurosis, we're really talking about something, it's a distress in thinking and behavior caused by, it really causes a deficit in daily functioning. Sorry, my words are not coming out today for some reason. It's usually characterized by anxiety, and that's pretty much when we talk about neurosis, that's one of the primary ways that it shows up is with anxiety, but it may also show up with depression or other emotional disturbances, okay? And then neuroses, we're just looking for a good definition of that. It's just sort of an experience of exaggerated reality. Going back to that, neurotics build castles in the air, right? I sort of make a whole lot out of nothing. They make a mountain out of a molehill, okay? So, and that causes a lot of anxiety in their lives and interferes with the functioning. So that's what neurosis is. Like I said, it's not a term that's used much these days. It's an older term, but every now and then you'll still hear it. So that's neuroses. Psychosis is a severe mental disorder in which the thoughts and perceptions are so bad that the individual really has problems distinguishing what is reality and what is not reality. In fact, that's sort of the definition of psychosis, is a break with reality. So neurosis, sort of an exaggerated experience with reality, while psychosis is I'm really breaking with that reality. What I'm seeing has no basis in reality. Okay, now certainly it's real to me, but it's not real to other people. Okay, not an objective reality. So some of the psychotic symptoms that we see with people may include visual and auditory hallucinations, delusions, and we'll talk about these a little bit more as we go along, sort of define those. Incoherent or nonsense speech that goes on, inappropriate behaviors, just general overall mental, emotional, behavioral dysfunction in all aspects of life. That's pretty much what we're seeing when we look at psychosis. Now, when we look at the difference between psychosis and psychopathy, and these are things that people often confuse, okay? And the reason they confuse them is because of this man, okay, Charles Manson, right? And that's the reason they confuse it because of him is because he's a psychopath, okay? We're looking at psychopathy there. He was not psychotic, okay? But he looks crazy, okay? He looks psychotic, but he wasn't. What he has is a psychopathy, okay? And psychopathy, when we're talking about that, psychopathy is a spectrum disorder on the antisocial scale, okay? So we look at antisocial personality disorder, and that's gauged on a scale. And the scale that's used to sort of gauge not only antisocial personality, but also psychopathy is the Hare Psychopathy Checklist, the PCLR, the revised version these days. That's the gold standard when you're diagnosing psychopathy. But that's once again, on a continuum. It's on a range, it's on a spectrum. The PCLR, it's 20 items that range from, you can score each of the 20 items. Boy, I've got a lot of spelling errors in this. Scoring it on a scale of 0 to 2. Now you have an individual scorer who's going to look at that, and they're going to say, okay, this criteria is not met at all, that's a 0, or it's most definitely met, that's a 2. Maybe some of it, maybe they may give it a 1. So you have people who are trained in giving the Hare PCLR, and they'll rate that, okay? They'll use an interview with the person. They'll also use records, court records, things like that, forensic files, in order to make a determination on that. So with a 20-item checklist, 0 to 2, 40 is the highest score you can get on there, and 30 is considered the cutoff for psychopathy. So anything 30 or above is going to be, you have psychopathy at that point. For an example, Ted Bundy scored a 39 on that. So remember Ted Bundy, the serial killer? He was almost a perfect psychopath there. I'm not sure which one he didn't score 2 on. Possibly the criminal versatility one might have been the one that he didn't score on. But when I was training with the Hare PCLR, we scored Charles Manson on that. And he definitely scored as a psychopath, but not this high. In fact, one of the other ones that we scored who didn't look psychotic, he didn't look crazy, he looked like pretty much like somebody from the street until you started talking to him and looking at the history. And then he scored higher than Charles Manson did, at least on my checklist he did. I think he did on a couple of others as well. This is psychopathy. When we're talking about psychopathy, we're talking about, once again, sort of on an antisocial scale. And antisocial, really what we're talking about is criminal, okay? Now, if you're looking at somebody like, schizophrenics, somebody suffering from schizophrenia, or any of these other psychotic disorders, in fact, most of my experience with them has been in the criminal justice system, they may end up there, but they end up there because they don't know what else to do with them, okay? It's not because they're engaging in criminal acts as a regular basis. That would be the antisocial personality disorder. But the other schizophrenia and the other psychotic disorders get there by just sort of by chance. And I'll talk a little bit about those as we go on. But that's the difference between being a psychopath and being psychotic, right? Psychopath is a criminal, okay? They're on that antisocial personality scale. They're at the far end of it. Whereas a psychotic is, I've got some problems with the brain, okay? The brain is not functioning for a variety of reasons, but the brain is not functioning the way it should, okay? So there's some things going on with the neurons, the way they fire, and lots of other things that are going on in the brain. And that's what causes this crazy, quote unquote, right, behavior. And when we're thinking about crazy people, we're probably thinking about psychosis. Okay. Just to go back to the psychopathy just for a minute, these are a list of the 20 items on the Hare PCLR. Glibness, superficial charm, a grandiose sense of self-worth, need for stimulation, very prone to boredom, pathological liars, okay? They like to manipulate people, they like to con people, and this is one of the reasons that you can't treat psychopathy. Is any sort of treatment, then you need to have somebody who wants to be different. And a psychopath sees no reason to be different. Doesn't matter if it hurts you, he doesn't care about you, or she doesn't care about you. So conning, manipulation is a way of life, even in prison. Okay, so even when they're sent to prison, they're still the ones who are causing the problems in prison. Lack of remorse or guilt. Okay, once again, they don't care. Very shallow affect. That's often described as they know the words but not the music. Okay, so they're able to say words that would make you think that they're fairly normal, but they don't understand what they're saying. They just know to say those things to get your trust so they can manipulate you. Poor behavioral controls, promiscuous sexual behavior, generally have early behavioral problems. In order to get antisocial personality disorder, you have to have conduct disorder, you have to be diagnosed with conduct disorder as a juvenile. Lack of long-term realistic goals. This is somebody who's, they're going to become the CEO of Tesla, right? But they didn't finish high school, and they can't really read or write very well, but that's what they're going to do. Impulsivity, very low impulse control, very irresponsible. Failure to accept their own actions, right? If this was one that always amazed me, that if they're stealing from you or something like that, it's because you left the door open. It's your fault. You should have locked your door. So lock your doors, okay? Because I've known people who just walk down the street and would try front doors to see if they could get in. And if they could, they just walk in and start taking. If somebody was there, then they say, "Oh, I'm sorry, I'm in the wrong house," and leave very quickly. Otherwise, they just pick something up and go, something of value, and then leave. Many short-term marital relationships, juvenile delinquency, once again, and a revocation of conditional release from prison. They've probably been to prison and they've not done well on parole, right? So they're back again. And then that criminal versatility, many diverse types of crimes, okay? So I just throw this in because people are always fascinated with psychopathy. When I used to teach at the university, it was one of the most popular aspects of the class in abnormal psychology was looking at psychopathy. So just to throw those in there, we're going to look at other disorders and some of the characteristics of that. And you'll notice that they're really nothing like those, okay? So another way to sort of distinguish those. Now, when we look at the schizophrenia spectrum, once again, schizophrenia is on a spectrum. It's a spectrum disorder, okay? It's like autism. Autism is a spectrum disorder. You can go from one area to the other, okay? According to your functioning and what have you. So the schizophrenia spectrum runs, and this is pretty much in order from light to heavy. The schizotypal personality disorder, schizotypal is a personality disorder. It's often put in with other psychotic disorders, but it's under the personality disorders. If you want to find it in the DSM-5-TR, go to the personality disorders. Then next, delusional disorder, brief psychotic disorder. And here we start to see some of the characteristics of these. For brief psychotic disorder, it's, you experience some sort of psychosis from one day to less than a month. Then after a month, it sort of disappears, okay? And we'll talk a little bit more about that and how that manifests itself. Schizophreniform disorder, that lasts from a month to less than 6 months. So you're seeing those conditions are starting to become longer. And then schizophrenia is at least 6 months. So you have the same Same characteristics. You have these same symptoms that are showing up for at least 6 months and then beyond that. After schizophrenia is schizoaffective disorder, then substance medication-induced psychotic disorder due to another medical condition. Okay, we'll talk a little bit about that and experience with that. Catatonia, and then there's always the other specified schizophrenia or other psychotic disorder, and then unspecified. So those are that's sort of the spectrum. Once again, I'm not going to talk about all of them. We don't really have time to go into all of them today. But I'll talk about the ones that I think you might come across yourself in your daily life. This might be something that you have to deal with, and that's what we want to look at. And then how do we deal with that as we move forward? So the defining features of any of the psychotic disorders, okay? These are what define psychosis: delusions, hallucinations, disorganized thinking, which you will often pick up during the speech. So the speech is disorganized, okay? How do you know what they're thinking? Well, you know that by what they're saying, right? So disorganized thinking speech. I remember when I was working in the psychiatric institution, I was doing an intake on a gentleman, and he only spoke in song lyrics, which you say, well, that was sort of organized. So what do you do? You know, so I'd ask him a question. Where are you from? You know, he'd say, there's a girl, my lord, in a flatbed Ford slowing down to take a look at me. Okay, so you're from Arizona, okay? so you just had to sort of figure out what he was saying as you did that. However, at some point he started to repeat himself on that. So I have a pretty good bank of song lyrics going, so I could pretty much figure out what he was saying up until the time that he started to repeat himself. So at that point, some disorganized thinking on his part there. Then grossly disorganized or abnormal motor behavior, and that includes the catatonia, and then negative symptoms. But psychosis, any of the psychotic disorders, these are the 5 things that we look for if you're going to diagnose that. So what are delusions? Okay, well, delusions are fixed beliefs, okay? Fixed beliefs that aren't amenable to change in light of conflicting evidence. So, I believe this, and you give me evidence that's to the contrary of that, and I'm not going to see that, okay? It's irrational, right? It's an irrational belief that I have. Now, there are many different kinds of delusions, okay? One of them is persecutory delusions. That's the belief that I'm going to be harmed, harassed by an individual, an organization, somebody, the CIA is out to get me. If you think the IRS is out to get you, you may be right. Let me just say, don't go to the doctor over that. You could be correct on that. But, I have, the men in black, are out there to get me, whatever. Persecutory delusions. Referential delusions are another type. That's the belief that certain gestures or comments, things in the environment are directed at me. Okay, so somebody's walking down the street and they're, it's windy and their hat almost blows off and they grab their hat. Well, okay, he's making a gesture at me. It's something with me. And they say, no, that's just the guy's, he was just grabbing his hat. Well, I don't believe that. Once again, and faced with the facts, I don't believe that because I'm delusional, right? So that's a referential delusion. I'm referencing something else out here to support my delusion. Grandiose delusions. When an individual believes, boy, Marty, you're going to have to start watching my spelling on these. I'm sorry. That they have exceptional abilities, okay? Delusions of grandeur. That's what these are, right? I have exceptional abilities. I have exceptional wealth or fame. I waltz into some place and expect everybody to treat me like a star, and they don't know who I am, and there's no reason they should know who I am. But I have these delusions of grandeur, okay? That's what those are. The erotomanic delusions, I falsely believe that somebody is in love with me. So I may believe that a movie star or somebody is in love with me, and I'll watch it. And some of these things may go together, right? So I'll watch, and they're doing a commercial and or something like that, and they look into the camera and, oh, I know they're looking at me, right? That little movement they made was directed at me. So maybe referential delusions going along with that. Jealous delusions, I believe that my spouse or lover is unfaithful, right? There's no facts to support that, but I believe it, okay? Nihilistic delusions, I'm convinced that a major catastrophe will occur. This one always reminds me of, I'm not sure it's a good example of it, but anyway, it always reminds me of, there was a show back in the 70s, I guess, when I was a kid, and it was about a guy who had got bitten by an animal, and there had been a plague sort of animals with hydrophobia at the time. And of course, with hydrophobia, they want to stay away from water and what have you. But this guy had gotten bit. They didn't know whether the animal was infected or not, but there was a lot of animals that were. And so this was out in the wilderness. They lived out in the wilderness, and they had to chain this guy up. And the father went into town to get somebody else and left him there with his son. This was a journey of several days, right? But as he was chained there, the guy started talking about the river. They lived beside of a river. He said, the river's going up. The dam is not going to hold. The river is going up. You've got to get out of here. It's dangerous. And of course, the kid's thinking, well, he's delusional, right? Because of the illness, okay? He's thinking a major catastrophe, this flood's going to happen because he has hydrophobia. He's worried about the water. Well, come to find out, he wasn't. It actually was a disaster. But anyway, it's sort of like that, right? So I see the water going up in the river or something like that, and I'm saying, that's not good. It's not good. There's a disaster going to occur, or any other things. That just made me remember that. Some of you may also remember what that movie was. I have no idea what it was. I don't even remember who's in it. I just remember the plot of it. And then somatic delusions. I focus on preoccupation regarding health and organ functions. So remember that anytime we diagnose, that's a rule out thing. And for many of these, we have to rule out things if it's delusions about the body, right? So we have to rule out body dysmorphia, right? We talked about that the last time I was here. So that's one of the rule out things. Is it body dysmorphia, or is it actually a delusion? Okay, so you're going to distinguish between those things as we go forward. Okay, hallucinations. Now, these are different from delusions. Remember, delusions are fixed thoughts that have no basis in reality, right? But hallucinations are perception-like experiences that occur in the absence of any external stimulus, okay? So I have auditory hallucinations, visual hallucinations, and they can occur in any sensory modality, okay? It doesn't just have to be audio-visual hallucinations, although those are the ones we commonly see. But there's no stimulus there for them that would cause them. They're vivid, they're clear, and they have the same impact on my normal perceptions that I would if somebody was actually speaking, was actually talking, or something was actually there. Okay, so I'm seeing things that aren't there. I'm hearing things that aren't there. This is very different from, you always have to distinguish between, if you ask somebody, do you hear voices in your head? Well, yes, I hear voices in my head. Yeah, okay, well, what is that like? You have to sort of pay attention to that, because oftentimes, we all hear voices in our head, or we should. That's called our thinking, right? That's the thinking we carry around with us. That's in our head when we talk to ourselves. That's not what we're talking about in this, okay? It's I can hear the voice from outside of my head. That's how you distinguish. So are the voices in your head, or are the voices coming from outside your head, okay? Well, if they're coming from outside my head, okay, then we may be talking about a hallucination. If they're coming from inside my head, that's just my thinking, okay? And sometimes you have to distinguish that. I mean, because people, not everybody is, cognitively oriented and things like that. And so they're hearing themselves in their head, especially young people. Is what I'm thinking of that a lot when I was doing intakes on the adolescent ward at the psych hospital and things like that. You sometimes had to make that distinction. As an adult, you pretty much know that that's coming from inside my head, that's my thinking. But with adolescents and younger individuals, sometimes you have to make that distinction. But once again, audio visual, those are the most common. The auditory ones are the most common of them, even more than visual. But that's what you're looking at there. Okay, that's a hallucination. Okay, and they must occur in the context of a clear sensorium. So something else is not interfering with it. Something else is not causing that. My senses are clear. I don't have any other things going on with my senses. Okay, the disorganized thinking, once again, a formal thought disorder. It's inferred from the speech, right? So somebody's talking and they just talk and talk and talk and talk and talk, not about the same thing. They go off track. That's derailment, right? When I go off the track, I have loose associations between we're talking about and what you're talking about are two entirely different things, right? Their answer, their questions are unrelated to whatever the question was, or it's very tangential to it. It really has no bearing on what we're saying. So that derailment, that loose association that goes on there as well. Speech may be incoherent, which is what I'm feeling like today with my speech. I'm feeling fairly incoherent. I would demonstrate some psychosis for you here. But we call that word salad, right? They're just saying words, but they have no meaning. Okay, so that's the disorganized thinking. Once again, we pay attention to their speech in order to get to the thinking. What are they thinking? That's coming out through their speech. And then you have that grossly disorganized or abnormal motor behavior, including the catatonia. It shows up in a variety of different ways. It may just be sort of childlike silliness, just sort of acting childlike, to very unpredictable agitation. So certainly the silliness is preferable to the agitation, but neither one of them are good. The catatonic behavior is marked by a decrease in reactivity to the environment. Okay, so something's happening in the environment and I react less and less to that. Maintain a rigid, inappropriate, bizarre posture. We may see that. We'll talk a little bit more about that when we get to the catatonia. Or a complete lack of verbal and motor responses, mutism, stupor, that's what those are. Can also include purposeless and excessive motor activity without a cause, okay? Catatonic excitement, okay? We think of catatonia as being sort of rigid, like we talked about previously, but it can also have movement there. Catatonia, it just means fixed, right? So it's a fixed behavior that just goes on over and over and over, and that's the catatonic excitement. Other features may include, once again, those repeated stereotypical movements. Staring, grimacing is one of them, and echoing speech, parroting back what somebody else is saying when they talk, which can be very distracting. Okay, and then negative symptoms. That's the last of the features of the psychotic disorders. And this is particularly associated with schizophrenia. We have diminished emotional expression, okay? So the expression of emotions, especially in a manipulation of the face, right? We can sort of, that's what we look at to see what somebody is feeling, what they're trying to convey to us. We look at that face, that facial recognition, what face are they making, what kind of eye contact are they making, the intonation of their speech, things like that. But we also may look at movements of the hand, the head, things like that, that give an emphasis to the speech as we go forward. Avolition may also be there, not only diminished emotional expression, but also avolition. And avolition is simply a decrease in motivated, self-initiated, purposeful activities, okay? I have no motivation to do anything, okay? So I'm just gonna pretty much continue doing what I'm doing right here. May include alogia, diminished speech output, anhedonia, a decreased ability to experience pleasure, okay? And once again, if we're defining this as a psychotic feature, we'll need to distinguish that from something like substance use, okay? So if I use substance, oftentimes I can experience anhedonia. In fact, especially if I'm using stimulants, cocaine possibly, but where I've seen it the most has been in methamphetamines. We have what's called, well, I won't go into that, but with stimulant use like that, long-term stimulant use, especially with methamphetamines, the dopamine system in the body can actually shut down, okay? And that means I don't experience any pleasure. And that's not a good place to be when nothing I do in this life can give me pleasure, okay? Now that's a little more intense than just anhedonia. Anhedonia is I don't experience that, but that is an anhedonic experience. And I have to distinguish, okay, have you been using methamphetamines for a long period of time and your dopamine system is just shut down? Is that the reason you can't experience pleasure, or is something else going on here? So you have to distinguish between that and asociality, which is a lack of interest in social interactions. And just let me go back for a minute. When we talk about antisocial personality disorder, remember that means criminal. Think criminal, okay? That does not mean that I don't like being around people. That's more asocial, right? So this is one of the things when I was teaching in the university and had in the graduate program there for psychology, I always had to remind the students, because oftentimes they would make these mistakes, is that they would say, well, I tend to be a little antisocial. So you tend to be criminal, you tend to have antisocial personality disorder. Well, no, I just don't like to be around people. That's not antisocial, that's asocial, okay? So let me just throw that out there for you. So in these psychotic features, when we look at negative symptoms, asociality, I don't like to spend time in social interactions, social discourse, things like this. That may be an aspect of it, okay? Not criminality, that's psychopathy, okay? Okay, so the first one, brief psychotic disorder, okay? I'll just start out and tell you my experience with this. I had one client when I was working in corrections. They had found themselves in there due to substance abuse, okay? But one of their diagnoses coming to us was also brief psychotic disorder. And what had happened was a really tragic and horrible event. But her stepson, I believe it was, had sort of gotten in a standoff with the police or something of that nature. And so they called her in to say, can you come in? Can you talk to him and, sort of diffuse this situation? And she was walking up to the front of the house, and I believe it was a mobile home. And she was walking up to the front, and she heard a shotgun go off in the backyard. And as she was walking up, the top of his head landed in front of her. So shortly thereafter, she had a brief psychotic disorder, okay? And when you learn these horrible circumstances, you can say, I understand, I understand why that sort of popped up. I understand that brief psychotic disorder. So because of that, she did have a brief psychotic disorder, but she also started using substances, and that's what got her into treatment where I met her. But brief psychotic disorder, presence of one or more of the following, and for all the psychotic disorders, these are going to come into place someplace, right? Delusions, hallucinations, disorganized speech, grossly abnormal motor, psychomotor behavior, including catatonia. Okay, so those things are going to come in, and at least 1, 2, and 3 have to be there. Number 4 is the grossly abnormal psychomotor behavior. So the first 3 has to include one of those. Duration is more than 1 day, once again, but less than a month. So 1 day to 30 days, this is what you're looking at before they go back to normal. Once again, you're going to see this same sort of thing throughout. Remember, when you're diagnosing, you're trying to rule out things. So if it's brief psychotic disorder, it's not better explained. The symptoms are not better explained by, major depressive disorder or bipolar disorder with psychotic features, or another psychotic disorder such as schizophrenia or catatonia. and it can't be attributable to physiological effects of a substance or another medical condition. You're going to see these sorts of things because, once again, if you're diagnosing this, you would, if those are the things, then you would diagnose those, not brief psychotic disorder. It's marked by emotional turmoil and overwhelming confusion. Once again, just given the example that I gave you, you can imagine, what that was like for her. Rapid shifts from one affect to another. Although it's brief, okay, it's less than a month, the severity of the symptoms can be very severe on this. Okay, so it's not something to just because it's brief psychotic disorder, that doesn't mean, oh, it's a low level of psychosis. No, it can be very severe. It's just the time that makes it brief. And then increased risk of suicidal behavior during the acute episode of that. So that's the brief psychotic disorder. You may experience that, in your life if things happen with people. If I'm dealing with family and someone dies or something like that, then often the stress of that can cause a brief psychotic disorder. So it's certainly something that we can, we don't have to work in a psychiatric institution to come across this, okay? This may be something that I see in my daily life. Once again, it's not going to last a long time, less than a month, but those symptoms may be severe. So we certainly have to take them seriously. Schizophrenia, whenever we're talking about psychosis, of course, schizophrenia is the one that we think the most of, okay? Our minds just sort of go to schizophrenia. It's interesting that when I worked in the psychiatric ward, I'd read some papers on schizophrenia at the time was being looked at as a disorder of terror, okay? And the reason they came up with it as a disorder of terror was that they said, where else do we see people who have these same symptoms that we're seeing in schizophrenia? And they said, well, it's people in war. It's people in active warfare that's going on. This is what we're seeing, these same symptoms. And so the people in war are experiencing terror. So they were sort of defining it as a disorder of terror. And when I worked in the psychiatric ward, I would often, if somebody was diagnosed with schizophrenia, I would talk to them about that and say, what do you think about this idea? This is a disorder of terror. And we'd talk a little bit about it. And almost always they'd say, yeah, that sounds about right. That sounds pretty close to it. So it's definitely something we don't want. If we can, we want to help the people who have this, but not a good thing if we consider it a disorder of terror, right? So the diagnostic characteristics for this, 2 or more of the following, each present for a significant portion of the time. And remember, this is 1 month to 6 months, right? So at least during that 1 month period, for a significant amount of that, they're going to experience these. Once again, delusions, hallucinations, disorganized speech, grossly disorganized catatonic behavior, and negative symptoms, okay? And once again, at least one of those symptoms must be delusions, hallucinations, or disorganized speech. You're going to see the same thing over and over again, like I said, because those are the characteristics of psychosis, right? So they have to be there. For a significant portion of the time since the onset of the disturbance, there's got to be a disturbance in the function in a major area of life, right? We don't like to make any sort of diagnosis if there's no dysfunction in the areas of my life. If my work life is not interfered with, if my interpersonal life is not interfered with, if I'm taking care of myself, then what's the problem, right? I mean, what is the real problem that's going on? So we always have to look at that and say, how is this disturbing normal everyday work experience, normal everyday interrelationships, self-care, things like that. And once again, it has to be continuous for at least 6 months. A schizoaffective disorder and depressive or bipolar disorder ruled out. Once again, we're always trying to rule out different things. If it comes up as something for these, then those would be what we're diagnosed, not schizophrenia. And the disturbance is not attributed to physiological effects of a substance. Once again, if there's a history of autism, being somewhere on the autism spectrum, or a communication disorder from childhood, then an additional diagnosis of schizophrenia is made in addition to those things, only if prominent delusions, hallucinations are present for at least 1 month. So we see how important it is for any psychotic disorder. We're looking at delusions, we're looking at hallucinations, things like this. Now, there's a lot of things that go into schizophrenia. In fact, at one time, I recall sort of schizophrenia on trial, right? In a forensic setting, a lawyer had asked a doctor a psychiatrist to define schizophrenia. And the list of things is really so great, or it was at the time. It's fairly clear here, but at the time that he said, you know, we know it when we see it. Okay, he couldn't define it, but he said, I know it when we see it, we know it. So the new definition that we have, the new diagnostic criteria we have, it seems fairly straightforward on this. Okay, now we have to rule out some things. We're always ruling out things, but it's much better than what it usually. Go back and read, you know, other DSMs, earlier DSMs 3 or something like that. And, it's sort of confusing on this, but schizophrenia is, once again, what we're most likely to come across on this, and it's hallucinations, delusions, the negative affect, the things of this grossly disorganized speech and behavior. These sorts of things are what we see, and these are what we define as crazy, right? Quote unquote. Let me just say that. Not an official diagnosis. Crazy is not an official diagnosis, right? But these are what the common people on the street are going to see. That guy is crazy, right? We're seeing these symptoms that are caused by schizophrenia. And when we look at the causes of schizophrenia, once again, it's oftentimes chemical imbalances in the brain. The brain's just not working right. Okay, it's not behaving the way it's supposed to. The electrical circuits, you know, are not firing the way they should. So that's the reason that these symptoms may manifest themselves. For schizophrenia, it's usually in late teen years, early 20s, about that time. That's pretty much when these start to show up. And so the ones that I worked with were less than 18 years old. So those were more the ones on the adolescent ward at the psych hospital. But that's when these start to show up, and it's not good. Untreated, it can just get worse and worse and worse, okay? So definitely it's something that we want to take seriously and do what we can. Now, I always like to throw this part in there, sort of, you know, it's Hollywood, so is it 100% accurate? No, okay? Don't believe everything that comes out of Hollywood, or may not believe anything that comes out of Hollywood. But anyway, there are some movies that have characters in them who suffer from schizophrenia. And if you want to see sort of what that looks like, you can look at these. If you Google a list of movies and schizophrenia, you're going to come up with a lot of things that aren't actually schizophrenia. What you're going to come up with is a lot of things that are psychotic. Okay, they fall into the other psychotic disorders. Okay. But not necessarily schizophrenia. So these are some that sort of look at schizophrenia. A Beautiful Mind, you may be familiar with that, the character John Nash, okay, who taught at university there, taught at Harvard, I believe. Now the movie, once again, the movie lied. It's Hollywood, and it lied in a couple of ways. Number one, his wife did not stay with him as long as she did in the movie. Okay, she left fairly early. And the other thing, at the end of the movie, he says, there's some new psychiatric drugs that help me deal with this. Nash stopped taking psychiatric drugs almost immediately after he started them. So he was not on medication for this, but was able to still function in his life with schizophrenia. He taught at the university, won a Nobel Prize. So he was able to do that. But certainly had some problems. At one time, he thought he was the emperor of Antarctica. I guess nobody else wanted it, so so it sort of fell to him. I don't know who could deny that. But that particular movie with John Nash, Russell Crowe is in it, I think. And if you've seen the movie, you know what it's talking about. Where he's saving the world. He's a spy master, and he's stopping all of this stuff. And none of that was true, right? At the end of the movie, I won't do the spoiler, but at the end of the movie, we sort of also see some other things that are hallucinations, right? That he's having. Not only those delusions of grandeur and things like that, and later delusions of persecution and things of that nature, but also some other ones, some other things going on. The Caveman's Valentine, the character of Romulus. I haven't seen this one. I did read about it, so it seemed to be an actual representation of schizophrenia. If you want to watch it. Spider is an interesting one. Ralph Fiennes is in that. 2002. I've seen this movie. It's pretty good. Okay, realistic. Well, I don't know. It gives you a good idea of what psychosis is like. Okay, as you watch the entire thing, you can really see what's going on, sort of in the mind and like that. It's a good movie. And then The Soloist, based on a true story of Nathaniel Ayers, who was a celloist. He also suffered from schizophrenia. So there's a lot of other movies out there, like I said, that if you Google it, they'll pull up, but they're not necessarily schizophrenia. They may be another psychotic disorder, and some of them are even psychotic disorders caused by substance abuse and things of that nature. But these are some that might be worth your while to look at for enjoyment. Now, substance medication-induced psychotic disorder, this is often something that we may see as well. If I have loved ones who are on medication, okay, or if I have loved ones who may be abusing substances of some sort, this may also pop up. Certainly, those are common things in our society, so may very well see these in your daily life. The first characteristic, that criterion A, presence of either delusions or hallucinations. Okay. Then there has to be evidence from the history, which includes a physical examination, laboratory findings, or both, that the symptoms in the delusions or hallucinations developed after substance intoxication or withdrawal, or after exposure to or withdrawal from a medication. And then the substance or medication has to be capable of producing delusions or hallucinations. Otherwise, okay. Then C, the symptoms are not better explained by another psychotic disorder. Once again, doesn't occur exclusively during the course of a delirium. Okay, if I'm delirious, that's a different story. Can't diagnose this in the presence of a delirium. And then the disturbances cause clinically significant distress in the important areas of functioning in my life. Once again, that's going to always be something that we look at there. But this is one, once again, that you may see pop up. One of my papers when I was in graduate school at St. Ed's, go Hilltoppers, was it was on substance-induced psychosis. So this is one that I'm a little bit familiar with. Plus, I've worked in substance abuse for the last 20 years. So every now and then this pops up. This isn't something that is generally long-term in my experience, right? That I may have a substance-induced psychotic disorder. I was going to say, I can't think of a long-term case of this really. Most of the ones I've experienced are sort of short-term. They get over them. But no, I can think of, I didn't work on this case personally, but I can recall one particular one that had to do with substance abuse. It had to do with PCP. And just mentally, the person was just no longer there after they did in so much PCP that the psychosis just took over, and there was never any. I don't know that they're dead yet. They may still be alive, but it's long term. Okay, so I was like I said, I was going to say I don't know a long term case of this, but very well it could be. I'm just not familiar with it personally. most of this is sort of short term as you move forward in your life. Okay. Psychotic disorder due to another medical condition. This is another one that you may have experience with. And I'm thinking, for example, of my grandmother on this. My grandmother had a history of heart attacks. That's sort of genetic in our family. I'm trying to avoid it myself. But she had several of those, and she was living with us at the time and had some heart issues. I think she had been in the hospital for another heart attack. I don't know whether that was 5 or 6 or whatever it was. But she was at home, and I remember that we were eating, and she said, "There's worms on that food." And I had to tell her, no, there's no worms on that food. But the stress of the medical procedure itself, the stress of the heart attack, the stress of going through surgery, of all of this stuff. Now, it could have been due to the medication, possibly, but I think it was more related to the stress of it and what have you. That caused the hallucinations that she was having. She was seeing things that weren't there. And let me tell you this, you never promote the psychosis, okay? So you may see a movie where, somebody said, "Oh, there's squirrels running around everywhere," when obviously there are no squirrels running around in their room. You don't go and go, "Oh, there's one. Yes, I see them." No, you're entrenching the psychosis. Never, ever do that. Okay. Now, you can't reason with them, right? You can't reason with them because it's a delusion. You can't reason with them and say it's not really there. Okay. Because they see it. And, when my grandmother did that, there's worms on that food. I had to say, grandmother, no, there's not anything there. And she ate, but she didn't. I could tell that she was still seeing them, but she took my word for it and was able to do that. But she was still experiencing that hallucination when she did. So this is something, because our loved ones may have medical problems, they may go through medical procedures, that the stress of all of that stuff that's going on, that could produce a psychotic disorder. Okay. Also, the medication, the one that we talked about previously, substance or medication induced, that could as well. They start a medication, it's something new, they haven't been on. And so the medication itself, if the medication is capable of causing hallucinations and delusions to begin with, then they could very well experience that. And so that's something that we may run across, okay, in our daily life. That's sort of the reason I wanted to focus on these. But as you look at this, it's the same sort of characteristics that we're seeing for all the psychotic disorders, okay? Hallucinations, delusions, these sorts of things, okay? Can't better be explained by something else, causes significant distress or impairment in daily functioning, right? So that's the psychotic disorder due to another medical condition. Catatonia, just to go over that, these are things, cataleptic, that comes from the Greek, which means fixed. Okay, so remember, it can be a fixed stupor. Okay, like the first one is no psychomotor activity at all, or it can be fixed motor activity, but it's a fixed activity. Okay, so stupor is one of the symptoms, and you got to have 3 or more of these to get catatonia diagnosis. The stupor, no psychomotor activity at all. I'm not actively relating to anything that's going on in my environment. Catalepsy, passive induction of a posture held against gravity. So a posture held against gravity is that. Okay, you can see me on there. Okay, I'm just standing there with my arm up. Okay, that's something. Oftentimes we'll see these, if you look at old movies and things of psychiatric wards back in the old days, oftentimes you'll see people just standing there with an arm up, right? And somebody will put it down and it'll go back up. So catalepsy, waxy flexibility, slight even resistance to positioning by the examiner. So if I'm examining that and their arm is up and I'm pulling it down, they're sort of resisting on that, right? They're sort of going to give a slight even resistance to my trying to lower their arm. Mutism, of course, no verbal response or very little verbal response is going on. Negativism, opposition or no response to instructions or external stimuli. So anything that's going on around me is not making an impact. I can tell you something, I can ask you a question, I can tell you to do something, no response whatsoever. And then posturing, spontaneous and active maintenance of a posture against gravity. Okay, just pops up there, okay? And I'm holding that there for hours on end, right? Hours and hours and hours. It's not like I hold it up for a few seconds. Hours, okay, that go on. Mannerism, odd circumstantial caricature of normal actions. So, you know, I think of Monty Python, the Ministry of Silly Walking, right? When I think about this sort of thing. Stereotypy. This is repetitive, abnormal, frequent, non-goal directed movements. So it keeps going on over and over and over. It has no real goal. I'm not doing it because I want something to happen. I'm just doing it. Okay. Agitation, not influenced by external stimuli. So, I mean, if there's a good reason to be agitated, then certainly there can't diagnose that. But if there's no reason for that, no external stimuli that's causing that. Grimacing, once again, I think we all know what a grimace is, okay? So the face sort of sticks in that grimacing. Echolalia, mimicking another's speech. That's the echo part of that, right? So making fun of the way you talk, not so much making fun, but I'm mimicking it in a way, but it usually comes out that way. Echopraxia, and that's where I mimic your movements, okay? So if I say something, please don't repeat that, right? That's mimicking another person's speech. Or if you do something, then I'm going to mimic those movements. That's the echopraxia that's there. Got to have at least 3 of those 12 in order to get that diagnosis of catatonia. So those things may be going on, and get that definition. So how do we deal with this? Okay. Well, I can make this very short. We deal with it with love, with caring, and with professional help. Okay. That's the one thing that you're going to have. Okay. You can say certain don't do things, right? Don't ignore it, because some of these symptoms, remember, even in brief psychotic disorder, the presence of the symptoms, the appearance of the symptoms can be severe, right? So we don't want to ignore that. We don't want somebody getting hurt, okay? So we don't want to ignore it, but at the same time, we want to get professional help with it if we can. And as we look at some of these, we'll talk a little bit more about this. But there's certain ways to deal with this. We can do it with psychotherapy or with medication. And if we're doing psychotherapy, it's going to be cognitive or cognitive behavioral therapy that address the delusions. Remember, delusions are fixed thoughts, fixed beliefs, right? Fixed thought is a belief, okay, according to cognitive therapy. So we have that going on. We have those irrational fixed thoughts, so we can address those through cognitive or cognitive behavioral therapy to help acquire skills that help us deal with that deal with the illusions. Psychosocial skills also can help with this. I've got some of the research in here. We can look at that. And then also family therapy. I want to talk a little bit more about there as I look at the research as well. So for this particular one, this is some of the research on this. This is in-home psychosocial skills training for patients with schizophrenia. Okay, and they found out that when they did this, that this, this was the experimental group. They had a control group, which is mainly medication, medical help, things like that. And that really the skills training provided people who had more effective ways of dealing with things that are going on around them than just the normal treatment did. Okay, so they were trained in home with these psychosocial skills, and by doing that, they were able to make some progress in this. Okay, and once again, this is just psychosocial skills that are going on as we're treating those. This was 2006, and I say that because the next one is in 1975, and what that is Soteria, and it's a home-based treatment program for schizophrenia. Now, this was originally practiced in Scandinavia. They're the ones who really started this home-based treatment model and what have you. And they had very good outcomes with this. Okay, psychosocial functioning increased when they were able to keep the people at home rather than locked up in a psychiatric facility someplace. When they were able to treat them at home, they came out pretty well. Okay, they did pretty well with that. Now, obviously, they would have a nurse or somebody come in as well, but the people were staying at home. Okay, so they were having very good results with this. And then there's another one that looked at this in 1983. They looked at it. They sort of did the same thing, evaluation of home care treatment. They found it worked well. Okay. In fact, if you read the bottom of it there, the home treatment, once again, they had a nurse there, had better clinical outcomes than just people who were given normal treatment, and treatment modalities more economical. They're not, it's not a burden on the family. It's not a burden on the state. They're at home doing this stuff where they would be anyway. So once again, and that's in 1983. I thought there was another one here. Okay. There was one that sort of looked at the follow-up. It was a follow-up to the 1975 study that they did. And it's about this time, okay, that you see the home stuff sort of disappear from the research literature. And why do you see it disappear? It's not because it didn't work. In fact, we know that it did work, okay? It disappears because we started coming up with medications, okay, that could more easily do that. So we take the more easy route on these, okay? And some of these medications, these are the old medications. These are the first generation antipsychotics. These have been around for a long time. Thorazine, Haldol, those are a couple of the more common ones that have been around forever. They're still in use, okay? I'm not going to go through and look at those individually on symptoms and what have you. But, Thorazine, in psychiatric wards, that was called the Thorazine shuffle, right? That people would just sort of shuffle along with their feet on the floor, never lifted them up, anything like that. That was called the Thorazine shuffle. Can I control your behavior? Sure, I'll shoot you up with enough Thorazine. I sure can. Okay, you're not gonna go very far with that shuffle. Okay, Haldol had some other things. The big thing about these were that long-term use of any antipsychotic, whether it's these first generation or the next generation atypical antipsychotics, they're iatrogenic, right? And iatrogenic means they cause harm. And we know they cause harm. We know long-term use of these causes harm. And what does it cause? It causes, for one thing, it causes tardive dyskinesia. This is the sort of the tics that you see people standing in a facility that they may be just sort of standing there doing that continuously over and over again. That's sort of characteristic of tardive dyskinesia. You may know a little more about it because these days they have commercials on television advertising medication to assist with tardive dyskinesia. We've been giving antipsychotics so long that enough of the population has tardive dyskinesia that now we have to advertise treatment for it on television. Okay, some of the second generations, you may see the atypical antipsychotics. You may see these advertised, Abilify, right? Some of these on television that come out. These are some more of those. Latuda, Zyprexa, okay, those sorts of things. So these are different ways that we can medically do this. Just for long term, however, long term, it's going to cause other problems. Okay. If you've ever worked with somebody who, if you're a professional, if you've ever worked with somebody who is psychotic, maybe thanking the stars, right, that they actually have these, because let me tell you, if you're in a psychiatric ward dealing with people with psychosis, which many of them are to get there, okay, then you're sort of thankful that these things are there. Now, the psychiatric facility that I worked in did not use restraints. They did not use physical restraints, and they did not use chemical restraints. So a lot of these things were out, okay? They did have what we had an isolation room, that we would put people in the isolation room, and they had what the clients affectionately referred to as booty juice, which was just liquid Benadryl. Just to help them sleep. So you better calm down or you're going to get the booty juice. The residents would tell each other. Okay? So they're going to get the shot to help them go to sleep there. But anyway, so if you're dealing with that and you're not giving some medications first off, if they just started the medications, they're waiting for them to take effect. Okay, you might have to deal with some strange behaviors, those sort of crazy, once again, quote unquote, behaviors of people with psychosis. And oftentimes, let me just say that when those clients came in, sometimes you didn't know whether to call a psychiatrist or to call a priest for an exorcism. And I'm not being facetious here. I can remember one, my boss was talking about a young woman who came in. They had just put her in the isolation room. She said she turned her back and she heard this long string of obscenities come from this young woman, and then heard a splat. And she turned around and looked, and the woman had defecated in her hand and slapped it on her wall and started smearing it on her body. So, times like this, you may call the Monsignor, right? Or do I need the psychiatrist? So, but she got straightened out. She was okay. But certainly, if you're in those situations, you might be thankful that these medications exist. But once again, long-term use of those is going to cause some problems, some other problems. One of those being tardive dyskinesia, and that's the reason you're seeing the commercials for it on television these days. I'm not saying don't use them. I'm just saying long-term use has other problems as well that you're going to be dealing with. So it's sort of, what problem do I want to deal with? But once again, if you're dealing with psychosis in your daily life, outside of being a provider in an institution, then these are some of the things that you might run into. Hopefully it's just for a brief period of time. If it's caused by the medication may get straightened out. If it's caused by stress from other medical procedures, they'll get that under control, okay, usually with some medication or what have you. But, don't reinforce the psychosis. These are the don'ts. Don't reinforce the psychosis, right? Don't go along with it. You're not doing them any good reinforcing delusions and hallucinations. Don't do it, okay? And I've seen so much on television shows and things like that where, you have the brilliant young doctor who goes and does this. No, do not. You're not helping them. You're only reinforcing the illness. So don't do that. At the same time, don't try to reason with them. This is like trying to reason with someone with dementia, okay? You can't do it because the brain is not working correctly, okay? Now the brain, we can get the brain figured out if we're dealing with psychosis. We can get the brain straightened out where we can start to deal with them using more cognitive behavioral techniques and things like that. But until then, don't try to reason with them because their brain is not capable of understanding it in the shape that it's in. So don't do that. But do seek professional help. If you think this is going on, seek professional help so somebody can, once again, maybe come in, assess this, decide that, what we need is some medication, maybe just to help you pass this brief period. In other cases, it may be more long-term. But seek help, and that's help for yourself, okay? Because you know, professionals wear out very quickly when they have to deal with this all the time. So you, as an individual who's not a professional, who's just trying to deal with it in your daily life, you may be better than the professionals at doing it, but it's going to get old after a while. I remember William Glasser, founder of reality therapy, talked about his early days. He started out in the VA hospital working in the mental wards there. And he said whenever he had somebody who came in who was psychotic, there was one particular orderly that whenever that orderly was on staff, when they brought those people in, by the next morning when Glasser would come in, the orderly had them and they were in a relatively calm state of mind. The patient was, and was doing they were calmed down and doing fairly well. And he didn't use medication for that to achieve that effect. Glasser never mentioned what he did, however. I'm sure he asked and I'm sure he found out, but doggone him, he never mentioned it. He wrote 100 books and never talked about it in any of them that I know of. I really wish I knew what that orderly did. Right? He wasn't a doctor. He was just an orderly at the hospital. But he had a way to deal with people like that. Once again, I'm imagining that it's a very empathetic, a very caring sort of approach to people. That's what we need until we can get some professional help and some medication and what have you to go along with that. Okay, there's some other ones. Atypical antipsychotics. These are probably the most I've had the most experience with: Seroquel, Risperdal, and Geodon. Okay, and if you want to put money in something, put it in Seroquel, because the people I know who've been on it refuse to get off of it. They'll have a knockdown, drag out fight with the psychiatrist if he wants to change them on that. Seroquel is, once they get on it, they don't want to stop it. So put your money in Seroquel. But anyway, those are a few more of those. Like I said, those are probably the three I've had the most experience with in my particular experience. Okay, all right. Do we have any questions now? If I can, I'll try to answer those in the short time that we have left.
There's several people that have some questions, and what I'm going to do, I think, is I'll go ahead and review the CEUs and give you a chance to look at the questions. Is that all right?
Okay. Yeah, would Benadryl not be considered a chemical restraint? Well, no, it just makes you go to sleep. It doesn't actually prevent movement. A restraint is something that prevents movement. So we, like Thorazine, that's something that prevents movement. You can't pick your feet up. You got to shuffle around. Okay, so it wasn't really considered a chemical restraint because it didn't prevent that movement. I just went to sleep. If you gave that to me. That was my understanding of it at any rate. How do we get home psychotherapy for those on SSI? Okay. Tardive dyskinesia. Yes, I believe that's right. TRDIV-DYS kinesia. Yes, that's correct spelling. Marty can perhaps give you more information on that. EMDR for schizophrenia and other psychosis. Yeah, I can see where that may work. I mean, EMDR is used for a lot of things that it was never originally intended for these days, and I hate that because it works so well for what it is intended for. What it is intended for, it's a technique. It seems to have become its own therapy these days, but it was a technique used in cognitive behavioral therapy. This is the one where you watch they'll either use their finger or a little wand with a little light on the end of it, something like that. So you move the eyes when you become excited. So I'm talking about a traumatic experience in my life, and I really can't go on. I'm so caught up in this. I'm so anxious. Do the EMDR, and I'm able to then calm down and talk through it. That's what EMDR was originally for. However, if we look at schizophrenia as a disorder of terror, then EMDR may very well have some application to that. I'm not sure how they approach it in the book. I haven't seen that, but I could see where that could come in. Yeah. Divine Secrets of the Yaya Sisterhood. I'm sorry, I haven't seen that, so I can't speak to it. How do you differentiate psychosis from dementia and delirium and effects of UTI? Okay, delirium is delirium's usually is a completely physical cause, right? We usually think of fever or something like that that can cause delirium. Okay, that's certainly different from psychosis, which has to have delusions, hallucinations, without that physical cause. Okay, without that external cause to that. So we distinguish between psychosis and delirium that may be caused by the effects of something else. So the psychiatrist could come in, he could look at that and say, okay, this is during the presence of a delirium, so we're not going to look at this as psychosis. Dementia, how we distinguish that, once again, dementia is some certain aspects of it may look familiar, but dementia is a little bit easier to recognize because, once again, the brain capacity, you usually see a steady decline with the dementia, right? So you're seeing a steady decline with that. Psychosis can just come on like that, and then it's there for a month, 6 months, a year, or even after that, longer after that for a lifetime. So that's sort of the differentiation you would make. Although some of the things, when I know that I was thinking my grandfather, there's a period in something like Alzheimer's disease, when you're looking at dementia, there's a period in there where they can go through a very violent stage. So you may be looking at that, where my grandfather could become very abusive verbally, and he was never that way, right? And we know that's just something that the brain has just gone, right? Dementia may be early onset dementia, but otherwise you're going to see that in older people. If the dementia is caused by something else, traumatic brain injury, something like that, then you're gonna be able to diagnose that. You're going to be able to look at that and tell when they do a intake with them. If we can get blood work done, can we figure out?
She has another.
I'm guessing there's another one up here.
Yeah, there's two above it. There's another one to start it off. My niece is in her 40s. Okay,
my niece is in her 40s. If we can't get her on her meds and she goes back to the streets, how do we get help for her? Yeah, I mean, if she won't go voluntarily, then unfortunately, then that's what's going to have to happen. She's going to have to wait till she commits a crime. And if she does, that's when you very well want to advocate and find an attorney, if you can get one, that advocates for treatment over just doing time, okay? Because just doing time is not going to help anything, okay? It's only going to make it worse, in fact. But if some of the best treatment, especially in the state of Texas, I'm not sure where you're from, but especially in the state of Texas, the treatment has to be, if it's in the criminal justice system, if CJAD has anything to do with it, has to be evidence-based treatment, okay? It has to be cognitive behavioral therapy, has to be certain aspects of cognitive behavioral therapy, because all cognitive behavioral therapy doesn't work, but certain parts of that. And so the criminal justice system in the state of Texas is very good at getting people treatment for this, but you're going to have to advocate for it, right? Because the waiting list on those places is usually pretty high, and they can spend that time in incarceration if they have to and decide if they like it. But usually they will go to treatment to get out of jail, and it doesn't matter if they do it. If they do it just because they want to get out of incarceration and go to a treatment facility, that's fine. Because what we know from the research is that coerced treatment works better than non-coerced treatment, and that is because they have to be there. Okay, if they're locked up in a treatment facility run by community-based correctional facility, something like that, where they're getting treatment, they have to be there. Okay, if you just leave it up to them, then maybe they won't. Now, if you can talk her into getting that sort of thing prior to that, that would be great, right? That would be wonderful. Otherwise, choices and consequences, but you can sort of take advantage of those. If unfortunately it turns out that they're arrested, then take advantage of that and get some treatment. Okay, there's some other movies there. Bipolar, borderline, off meds, street for over a year. Substance abuse involved, very probably, yeah. Well, yeah, bipolar and borderline don't usually evolve into schizophrenia. Schizophrenia will develop, but not from those. That's the reason where when you're diagnosing that it's either going to be, okay, it's bipolar, or it doesn't have anything to do with borderline, but it's bipolar or schizophrenia, right? Mother is schizoaffective, so certainly that's genetic. It runs in the family. And you said she was okay, I thought there was an age in there. Anyway, yeah, early 20s, somewhere around in there. It may very well be schizophrenia. It may develop schizophrenia, but it doesn't necessarily develop from bipolar disorder, okay? Borderline, that certainly makes it harder. Borderline is the only diagnosis that has one of the criteria for the diagnosis is suicidality, unfortunately. I mean, I've known a lot who didn't, but they engage in behaviors that leads to that. So more aggressive. And we get her back on meds. Well, the meds may definitely help the schizophrenia. It may definitely take care of the symptoms of that. Once again, if it's schizophrenia, not bipolar. If it's bipolar and you get her back on her meds, she needs to be there too, right? That'll take care of it in that way. Borderline stuff, that's a long road to hoe right there. I'll tell you, that's a personality disorder. So there's certainly treatment for it. There's certainly things she can do. I've worked with borderline personality for many years. Not fun, but people can make a difference in their lives, most certainly. So get her, whatever it's diagnosed as, get her on the appropriate meds and then get some treatment would be. Persons use meth to the point it interrupts their dopamine, their medication, it can offset it. Yes, there's not a medication necessarily. What happens is you go through treatment that includes medications that rehabilitate those pathways, those dopamine pathways in the brain, and eventually then they can regain that hedonia. Okay. Another thing, this is what I was going to say during the presentation that I didn't. The other thing is with stimulants is we have what's called a hedonic set point. And that set point gets set because we experience things in life and it goes up and then it drops, and we experience more hedonia and it goes up. And the top of that, where that sort of levels out, that's the hedonic set point that we have. In normal people, the two things that cause the most pleasure in our life are food and sex, okay? Meth is about 40 times more powerful than either one of those that you're ever gonna have, okay? Unless you have sex on meth, apparently I've been told. But what happens is we have that normal hedonic set point, then we use a stimulant like methamphetamines and the hedonia goes up. Once again, about 40 times more powerful. It comes back down, it goes back up past that thing. And eventually the hedonic set point changes, okay? This is called allostasis, okay? So it's just like the same thing happens with a fever that we have. So the hedonic set point, we're experiencing this pleasure up here. So the hedonic set point now comes up there. Well, I stop using drugs and where am I going? I'm only going to right here. So I'm going to experience this anhedonia, but eventually over time, it'll drop, that set point will drop back down and I'll be able to experience pleasure. During the time between I stop using and the set point drops again, that's when I'm most prone to relapse. But knowing that, this is going to correct itself eventually, this is where something like 12 steps, right? One day at a time, right? I'm going to do one day at a time because eventually this will change, right? So yes, it can change. And they do use medications if that happens to rehabilitate those pathways.
Doctor, there's two things in the, when they talk about approaches to responding. Can you go to the, the phone number? They wanted a phone number. Oh, I'm sorry. They're asking for the phone number for SSI. I'll include a phone number to our service navigation line when I do the email after we're all done. I'm sorry.
Okay, and hopefully I covered the approaches to responding to that. How do I respond? I respond to it with, with empathy, with caring, and getting professional help for that. Okay, I can't reason with people. I can't join in with them in the psychosis. When we talk about psychotic disorders, there's not a whole lot we can do outside of the medication to get them to a level where we can then use some some psychotherapy and what have you that may help them, psychosocial skills, things like that can also help them. So you're not going to do it on yourself. Don't try to do it with yourself, because it isn't going to work. You're just going to wear yourself out. Sarah Quill, okay. Bipolar, usually they might use something like Lamictal it depends on what the person can take and what have you. But Seroquel certainly is an antipsychotic, so you'll see it used in a lot of psychosis. Bipolar, maybe, but Lamictal is usually something that they use. Okay. All right. I don't see anything else, and I think we're over our time. Sorry.
Yeah. No, it's fine. Could we move to the CEU slide real quick, and then we're going to go to next month real quick. Yeah, just want to reiterate for those of you that may have joined us a few minutes late, the CEUs we're providing today are for licensed social workers and LPCs in the state of Texas. You can also get a certificate of attendance if you'd like. The rules for both of those are the same. We've had people get certificates for other licenses in Texas or license outside of Texas. There's no guarantee those will work, but you're more than welcome to get those. Today's webinar was good for an hour and a half of CEUs, classroom hours. You must complete the entire webinar. Can't miss more than about 10 or 15 minutes. I'm sorry, 5 or 10 minutes of the webinar to qualify. You must complete the Google survey. It should pop up when you log out of Zoom today. If it doesn't, you will also get that in a follow-up email that I'll be sending out in the next 24 hours. This Google survey will be up live for 1 week until a week from today, and certificates should be out to you by the week after that. Go ahead and let's go to the next slide if we could, Dr. Mottern. So our next webinar is identifying and engaging persons with autism spectrum disorder. It will be on Wednesday, June the 8th. Please join us for that. I will have a link to that flyer as well in the follow-up email. Dr. Mottern, as usual, incredible information. I mean, you can see by the compliments, everyone has just gotten a phenomenal amount of information out of today, and we certainly appreciate this partnership.
Thank you. My pleasure.
Absolutely. And y'all, if you have any questions after this, you can contact Dr. Mottern. You can contact me, and I can forward that on to him. But let's get your questions answered and get you the help you need for the people you serve or your family members. Thank you so much, and you all have a great day.